John, he is a uh, 11-year-old boy. He comes to you for his short stature. Now you have to take the history from John mother Mira.
Okay.
You want to take time or need to start?
Yeah, I will start now. Yes.
Okay, wait, start.
Hello, good morning.
Good morning.
I'm Dr. Teresa, one of the child doctor. I believe I'm talking to John mom's Mira.
Yes.
Nice to meet you. I'm here today because I want to ask you questions regarding John's conditions. Is that time
Mm.
suitable for you?
Yes.
Okay. So, Mira, tell me what is the main concerns regarding John's?
Wrong. John is main concern is that John is not taking his height. He is really short.
Yeah. When did you start notice that?
He started, I think, from the beginning. He is short, I think.
Okay. And is that only height problem, or do you have any concerns regarding the weight of John's?
No, I think it's only height problem.
Okay. Um, if you don't mind, does mom and dad may I know the height of mom and dad?
We have normal height, acceptable.
Okay, that's perfect. Who does John look like at home?
Yeah, he is look like both father and mother.
Okay, okay. Um, apart from these short statures, do you have any other concern?
No,
All right, okay. Have you tried anything for that?
you have gone GP for that reasons like 1 year back. He is telling it's okay, which time it will be okay, or telling that okay, let's see what happened like that.
Yeah, did you measure the height and then plot on the growth charts?
Yes,
Okay. And do you know the trend? Is this like a downward trend, or it is like the stand, like a plateau stand, like one?
he's short.
Okay, okay, all right. Um, eh, um, okay. Then I want to ask that: is there any others fever history of fever?
No,
No. All right. Does Jones has any problem with tummy, like any recurrent tummy pain?
no.
What about poo? Is his poo is normal?
Yes, his poo is normal.
Okay. Any history of sickness or throw up?
No,
Mm-hmm. Any discoloration of the skin, like yellow color?
no, nothing. I notice.
Does Jones has any histories of a recurrent chest bug?
No,
Any problem with difficulty in breathing?
no.
All right.
If possible, improve your volume.
Okay. All right. Um. What about John's activity? Can John's active like other child?
Yeah.
Oh, that's great. Is there any weather preference, like cold preference or hot preference?
No, nothing special. He mentioned me.
All right. Um, do you notice any skin change? I mean, skin rashes, skin spots,
No,
any joint swelling, joint pain?
no, nothing.
All right. Is there any atypical features that you are concerned regarding the joints, like extra fingers or anything else?
Nothing.
Okay, okay, that's perfect. Does Jones has any history of the headaches?
No,
What about his visions? Does he complain with any problem with vision?
no,
Okay. Any asymmetries of the bodies or face?
no, nothing.
Okay. Um, does Jones can play where you mentioned Jones can play where? So then I consider that he doesn't have any shortness of breath. Am I correctly interpreted?
Yeah,
Okay. Any history of chest pain?
no,
All right. Perfect. What about John's pee? Do you notice any problem with John pees?
No, nothing I notice.
Okay, perfect. John is 11 years old, so is he start his puberty?
No,
Oh, he hasn't started his puberty yet.
no.
Okay. Um, is there any member in the family like who have also have delay in starting the puberty,
Yeah,
or any
John
mom?
father also like that. He shared me that he was also short like John, but later he achieved.
Okay, all right. Does John has any past medical problem?
No,
Any history of hospital admission before?
no,
Okay, that's perfect. Any history of trauma or injury?
no.
Oh, that's great. I'll moving back. I want to ask the birth history. How was John born?
Yeah, he is born on a normal vaginal delivery.
That's great. Do you have any problems concerning John pregnancy?
No, nothing. It was smooth, uneventful.
Okay. Any problem after that, like postnatal periods?
No.
Okay. Does John receive all the vaccines or jab for his age?
Yes, he has taken up to date.
That's perfect. 11 years old. John is 11 years old. Do you have any concerns regarding John's movements, playfulness?
No, no, he really active boy.
That's great. What about the diet or nutrition? Is there any concerns you have?
Yeah, he's taking a regular diet nowadays. He thinks he can eat more, then he will get his height. That's why he's taking lots of food, protein, diet, everything.
Okay, that's perfect. So I think I have asked a lots of questions. Is there anything else you want me to know for?
No.
Okay, thank you so much for your time, Mira.
Thank you. Present your case. What is your diagnosis?
Okay, today I have taken a history from Mira, who is the mothers of John. John is an 11 years old child presented with a history of the failure to history of the short statures and then delay in starting the puberty. He doesn't have any other syndromic features or endocrine features. There wasn't any history, any birth history, significant birth history. The child is systematically healthy. There isn't any features of systemic illness. However, I've noticed that John Fathers has a history of delay in attaining the normal height along with the delay in starting the puberty. So, based on that history, I believe John is having a short stature, probably because of um, constitutional delay.
What is your DD?
Differential, it can be familiar short statures or it can be because of the
Okay, thank you very much for your participation. First of all, I want to tell you, you have completed the history like 9 minutes. 4 minutes remain. So the history
yes,
was good at the beginning, middle, but at the end you have forgot to take the familiar social and psychological history. That's you can
yeah,
take elaborately. Is any bullying in the schools or not? What was his
mm,
school achievement? Everything, family similar conditions like in perinatal
yes,
history. One thing, birth history, you have to ask mother taking any illicit drugs, illegal drug during his. What about the mother maternal age? As syndromic feature is one of the DD in our. So this
mm,
question you also miss, and any medication he's taking, his mood, he's really depressed. You need to ask me what about his mood. These are the questions. So normally when we tell short stature come on the exam, it either constitutional delay or familial short stature is our one of the DD because the mother and father also average. I told you.
yes,
Familial short stature also develop. And syndromic feature also come on the exam. Once come Turner syndrome also come. So Turner syndrome it come. It will be girl. She will be short statures and she has specific features like waved necks, white space nipple like that. Okay. Normally when short or tall stature, any history come this complaint, how can we analyze his first onset course and duration? How did you know that? Do you have or his growth chart? Okay, so my and his growth chart. What about weight and head circumference? His measure sitting height, standing height, and arm span. So any syndromic feature, I will know that his sitting height, standing height. We'll ask them any disproportion you will notice in his sitting height, standing height. Okay, is he started to be like a man or woman about his puberty? Size of the private area in boys and breast part in the girls. So on the way or not the puberty, very important. What about his parents' side? Age of the puberty of the parents in tall stature, in short stature. So age of the puberty of the parents and parents' height. Did you notice any unusual features? What about his mentality and intellectual functions? This also important for syndromic features. Any other concerns? Any chronic conditions? So lots of chronic conditions for short stature, that kidney disease, heart disease, lots of cause can be. Then after analysis, we are going the general condition like fever, weight, activity, sleep. Weight is very important here because hypothyroidism one of the cause of short stature. Recently maybe he's gaining weight. Okay, now we go the systemic review. CNS, sign of any increase intracranial temperature, signs like abnormal movement, abnormal gait, fits, numbness, various bug, vision concern, yellow eye, hearing concern, behavioral changes, and irritability. GIT about the tummy size, tummy pain, throwing up, yellowish discoloration of the eye, oral thrush, oral and anal soreness, anal itching. So GIT, poo is very important. Maybe he's constipated and hypothyroidism. Another GD. Chest or recurrent bugs, cough, snoring sound, CVS, snoring sound we find in weight obese persons. Now CVS about the heart racing, exercise intolerance, chest pain, fainting attack. Urinary about the peak concern, blood pressure, meniscus, skin spots, fingers, oral anal flexures, acne, abnormal hair distribution, hirsutism, lumps, swelling anywhere, neck swelling, hair, nail, bone or joint pain, curving of the back, any asymmetry in the bodies. Because the Beckwith-Whiteman syndrome or small hands or feet, Prader-Willi syndrome, and stria. So obese child, Prader-Willi syndrome also short stature. Then diet history will be very much important. Beckwith-Whiteman syndrome, asymmetry, endocrine hot or cold intolerance, and thyroid. Very important endocrine asking because hypothyroidism is one of the DD. Hematology, pallor, bruise, recurrent bugs, history of any blood transfusions. Past history as usual, 5T, IOA, any chronic condition he's suffering or not. Then trauma, traveling history, blood transfusion, surgery, and also if any chronic condition he is compliant with the treatment, details about his chronic condition, high diagnosis, what is the treatment. Okay, drugs, any drugs he's taken or not. Here if you ask me any drugs he's taken or not, yes, he's taking some illegal drugs because of his depressions, or he can be on steroid. Steroid side effects: methylprednisolone, methylphenidate if short, or sex hormones. Parental history very important: pregnancy, maternal disease, drugs, illicit drugs, delivery time, type fast cry, postnatal birth weight, NICU admissions, meconium passage, yellowish discoloration, feeding problems after birth, belly button loss, heel prick test. Heel prick test very important, and hearing test. Puberty, if it's on time, HATS history. HATS means the children. Normally, short stature come with adolescence. So adolescent, everything, going with the friends. How about his activity, depression, bullying, suicidal idea, anyone special in his life like that. Nutrition very important. If there is over or underweight, any feeding problems, type of the food, number of the meals who prepare food for him, and content in each bed. We need to ask everything. Your history has 4 minutes remain. So you have enough time to explore this. Development
Yes.
in detail, vaccination up to date, any extra shot, allergy, foods or drugs, family history of similar condition, consanguinity, social, if the child aware of his condition or not. Psychological impact, how does his condition affect the family? School, is he going to school? Is it mainstream or special school? If not, ask anyone talk to you regarding appropriate educational plan for him. So when come a short stature, first normal height or abnormal. Normal is familiar short stature or constant delay of growth. So our is a constant delay and familial short stature, 2DD. As it is normal, everything I'm telling no, 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 the answer. Then pathological is like that, uh, non-dysmorphic, which are like a failure to thrive, malnutrition, malabsorption, chronic illness, psychological dwarfism. So malnutrition, malabsorption, we keep in our mind. When we take a history, we search all this point that examination should need to know. We know lots of DD. Like dysmorphism, what are the dysmorphic features associated with that? Syndromic short stature, Down syndrome, Turner syndrome, Prader-Willi syndrome, Russell-Silver syndrome, Noonan syndrome, Beckwith-Whiteman syndrome. These are okay. These are Turner syndrome once come also in exam. Short stature. Prader-Willi. That's why diet history is very important. Then short limbs, sitting height, standing height. We are asking because the achondroplasia, skeletal dysplasia, rickets, osteogenesis imperfecta. This is short trunk, mucopolysaccharitis, scoliosis, post radiations. Then failure to grow, like growth hormone deficiency, hypothyroidism, Cushing syndrome, Albright hereditary osteodystrophy. These are also we keep in your mind in when you take the short stature. The question come, if it's considered delay of short stature, what we give the advice? Reassurance about the parents that he will be achieved. We'll advise him, and we will liaise with the school if there is any bullying problem, psychological support to the child and the family. This will be including our management portions. Indication of growth hormone they ask, because indication of growth hormone: chronic renal failure, Prader-Willi syndrome, Turner syndrome, growth hormone deficiency, small for gestational age, not reach fifth centile by the second year. This is the indication of growth hormone. Side effects of growth hormone they ask in the exam, that is pseudomotor cerebri, hyperglycemia, primary hypothyroidism, gynecomastia, liver abnormalities, acute pancreatitis, and adrenal insufficiency. So growth hormone related this question they are asking. They also ask
Okay.
about what is short stature. So height is less than third centile or less than 2 standard deviations, 2 SD, mean of the age and then sex, or growth velocity is less than 25th centile over 6 to 12 months. So height less than third centile or less than 2 SD, and growth velocity less than 25th centile over the 6 to 12 months, that is called short stature. And when we tell the failure to thrive, if it failure to thrive affect the greatly the weight gain and then height. And the linear growth affected usually secondary, short stature affect mainly linear growth, height. So our was height, you ask about me, his weight. I told you no any weight problem. Maybe it can be weight gain problem. Also, it can be failure to thrive, excessive weight failure to thrive. These are the difference. They ask what is the familial and the constitutional short stature. The familial is a family history of short stature present. Constitutional, there is delay puberty. Familial parent stature is short, one or both. Anyone can be short. Constitutional will be average. Puberty normal in familial, but constitutional there is delay. Bone age and chronological age. Familial age equal bone age equal chronological age. Example, no bone delay. But in constitutional, what happened? Chronological age more than the bone age. There is bone delay. Remember, familial there is no bone delay, but constitutional there is delay bone. Final height short. In familial stature, he will be short. Final height. But in constitutional, what happened? Normal due to normal growth in the prepubertal age. Height velocity familial is less than normal, where constitution is normal. These are. And if it is a constant short stature, we know that no investigation actually needed. But other for identification of cause, we can do lots of disease like stool analysis, urine analysis, CBC and blood film for anemia, any chronic disease, ESR for inflammatory bowel disease. These are iron study, chemistry. Lots of tests needed. Thyroid function test we can do, growth hormone binding protein, serum growth hormone binding protein. These are screening for celiac, screening for cystic fibrosis. These are the, if the examiner asks us what are the chronic condition, you can think, and we tell that growth hormone deficiency, any renal disease, kidney disease, any liver disease, celiac disease, cystic fibrosis. This causes this chronic condition and hypothyroidism. For that reason, we can search the investigation. Otherwise, not. So this is all about short stature questions, I think.
Thank you,
Okay,
Dada. Yes.
you're most welcome. Okay.